This, as Julia pointed out, is part of a long series of Genome Canada programs which we have the fortune to benefit from. In fact, it's our third major program. So the first three, for which we're just coming to an end now, address the question of, can we prevent rejection? And if I take a step back to the older days, and there's probably only Michael Ulrich and myself and maybe one or two others who are more senior in our community who remember the bad old days. And the bad old days, in essence, were before cross-matching, before cyclosporin. And in those days, we had an incidence of fulminant rejection of about 80%. And sometimes the rejections were so severe that the kidney would actually split on the operating table as you were completing the vascular anastomosis. And of those, about 50% of grafts would be lost in the first year, and 25% of patients would die in the first year. Now, over that time now, we've come to an era which we'll show you during the day today, and hopefully turn to tomorrow, where we have had profound, to me, and probably Michael also, almost bewildering success, where rejection is beginning to disappear in the rear view mirror. And this is due to many things, new immunosuppression and a whole variety of other things. But in essence, this third, thanks very much, that's great, you put it up. Okay, it's coming. This third grant, which we're now coming to the end of, asks the question, can we prevent rejection? Particularly, can we prevent antibody-mediated rejection? And the answer I'll give to you, I hope, is yes, we can do it with enormous success. And the next stage going forward is, can we prevent all of rejection? And the answer that James, I think, will give you a little bit later is, yes, we think we can prevent almost all of rejection, so that the risks dwindle to almost zero. And that takes us really to the title for today's question. If so, if we can now calm a raging sea, and we can actually end up with a sea like yesterday, which was almost like a mill pond, can we now look forward realistically to the induction of tolerance or some form of tolerance where we can begin to remove immunosuppression and have continued quiescence? Thanks very much. So those are the themes for today and tomorrow. Today really deals with where have we come to, and tomorrow deals with where will we go. So thank you again to all of our participants. You see some of the university logos. I haven't put the commercial logos on, but thank you all. We really appreciate you. Without you, we would not have been able to translate the technologies which makes this feasible. So when we started this third episode of our genome grants, the question was, can we prevent antibody-mediated rejection? And there were two seminal studies which we drew on. So remember, the grant started in 2017, but the planning started in about 2015 during discussions with Genome Canada, Genome Quebec, among the investigators. And there were two seminal articles at the time. The first came from our own Adrian Levy, who is one of our health economists, who analyzed the American data and showed that, yes, we have superb initial success, 95% initial survival, frequent early rejection, a lot of AMR, premature graft loss, early death, so that if we look at the figures by 10 years post-transplant, even in the best functioning grafts with a high GFR, 50% were lost, and about 30 or 40% of patients died. And if your function was poorer, you can see you did profoundly worse. And the second study came from Canada, was from Phil Halloran's group, around the same time, which in essence said that if you follow patients who have been biopsied, the principal cause of the demise of those grafts is rejection, and largely antibody-mediated rejection. It starts out with an incidence of antibody-mediated rejection of 10%, and it rises from that point on. So our goal was really to prevent it. We had no treatment at the time. The question was, could we now implement methodologies, stringent testing to avoid antibody detection, or to detect antibodies, and avoid pre-sensitization, and other ways to minimize disparity that would enable us to move forward. We put forward 4 pillars. The first was optimizing matching. The second was personalizing therapy. The third was expanded post-transplant surveillance. And the fourth was evidence-based health policy. This was a pillar that we have kept in there for Genome Canada because we want to demonstrate, hopefully, the utility of the discoveries we make. We formed a large consortium of centers and investigators across Canada, in the United States, in Europe, and now many of the Australian sites are very keen to join us as well. So it's turning into very much a global consortium. But you can see we brought together clinicians, laboratory scientists, people working in genomics, molecular medicine, proteomics, right through to representatives from the regulatory agencies in the FDA and Health Canada. The goal was to make this a pan-Canadian program, but with an international input and advisory board. We drew together all of the key centers and all of the HLA laboratories across Canada. We worked with and partially under the umbrella of the Canadian Blood Services. We could avail ourselves of all of their programs, provincial programs, national programs, and their support services, which really differentiates Canada from many other parts of the world, certainly our neighbors to the south. Although Donald Trump may introduce this very shortly. Let's take pillar number 1. The goal was to optimize matching. So what I've left out of this is the current and parallel thread of improving the detection of antibodies and excluding pre-sensitization post-transplant. So as Ahmed and the team who actually work in the depths of the HLA laboratories every day know this has come a long way. We've started with relatively crude solid phase assays to try to detect pre-sensitization, which have become more and more refined over the past 10 years. We've been able to go from antibody level sensitization to epitope level sensitization. We'll talk a lot about epitopes. Epitopes really are the business points on the HLA molecule where antibodies bind. We think also that they're probably the immunogenic sites, but we still have to do a little bit more work there. So now we have come to the point that we can detect with great precision when antibodies are present. And Canada took a different tack from most other countries. We took an extremely conservative threshold, a very low threshold for detecting antibodies, and we avoided rigorously transplanting across those. Now, as many of you will know, our colleagues in the States and others take a different approach where they say, yeah, sure, they have antibodies, but we can give them more immunosuppression. We can overcome it. And you can to an extent. But if you really want to prevent rejection, you have to avoid pre-sensitization. And I think this has been one of the keys in the dramatic success we see. So the other approaches are use of structural biology, nanopore sequencing, and I'll explain why that's important, and Canadian programs for epitope matching. When I first came to BC, which was in '87, it's to the left end of this green curve that you see there, we knew very little about the genetic structure of the HLA complex, which is actually a very complex series of gene sequences. And now you can look and we're nearly at 40,000 known alleles at the moment, 39,000 just a month or two ago. So dramatic increase in the complexity. And we now know why these differ, and it's because the epitopes, these little small amino acid sequences shown in red in the graph on the right-hand side, are the business points at which we differ from one another and which are the triggers for rejection. Now, these so-called epitopes are shared, and we have class 1 molecules and class 2 molecules. In class 1 molecules, Oliver Gunther, who works with us, has actually shown the distribution, and these are shared between many of the classes A, B, and C. But in class 2, they're much more confined. So epitopes at DR stay largely within DR. Epitopes in DQ stay largely within DQ, and so on. And we begin to ask, now is it possible to share for some of these? Because there are somewhere in the region of 100 to 170 or so epitopes compared with 39,000 alleles. So the complexity of the question is much reduced. And the answer is yes, this is some early work done by Jenny Tran, who is one of our partners here. And you can see that the black line shows what actually happens in the real world. These are patients, 1,000 patients who were transplanted, and we asked, what was the closeness between the donor and the recipient? And as we go from patient 1, 2, 3, 4, and so on ranked, you can see that the median is somewhere here around, let's say, 30 mismatches. This is for all HLA genes. If we actually had the chance to reallocate those donors to the best match, it would dramatically reduce it. Not perfect, but reduce it dramatically. Now, we have a lot of reason to believe that not all genes are equally important, that the class 2 genes are perhaps more important, and among the class 2, the DQ genes are the most important. So now we can begin to look at DQ and ask, if we actually reallocated these donors to the patients, would we have a better match? And the answer is yes. We have an over 90% chance that we can match with a 0 mismatch, which is dramatic. So that now answers the question of feasibility, because it's no use considering something which might be really interesting, but is not practical. This is both interesting and practical. And we find some other really interesting things. When we rank all the patients and look at feasibility of matching them, there are some people who can be matched readily, and there are other people who are much more difficult to match. These are the ones we're concerned about, because we don't want to leave people sitting on a list now for 5 or 10 years. We need to find a different way to deal with these people, but we know right from the first day they come for assessment, we sequence them, we can say, you're likely to be more difficult to match. We need to think of a different bypass route for you. So now we can begin to think, how would this work in Canada? And we can actually look across the total number of recipients who are waiting on the waiting lists in Canada. Now, if we have a very small waiting list of 10 people, it's going to be hard to get a good match for everybody. But if we have a waiting list of 1,000 people, then we have a very good chance because the pool is bigger. So most centres in Canada have waiting lists of around 300-400, most of the big centres, 300 or 400. Some smaller ones that are way down here. This is the total Canadian population. So we asked an important question. Do we need to allocate and share across the whole of the Canadian population, which brings logistical problems? Or can we do it within most of the big regional centres, Quebec, Vancouver, Ontario? And the answer is yes. Once you get to a waiting list size of about 300, you can achieve very good matching within that. Now, there's a second way of matching called PERCH, which looks at T-cell epitope matching. And it's used much more extensively in Europe, but we have been working with Matthias Niemann and various people from the group there. Thank you, Matthias, and the PERCH group. We really appreciate it. The question was, does it look the same? And the answer is yes, it looks very much the same. And the same genes are important. So if we want to match using PERCH, for DQ loci, yes, we also have a very good probability of matching. Maybe about 10 points lower, but still of the same order. So this gives us great confidence that the direction we're moving in is actually logistically sound and clinically feasible. Now, we have to think, what are the epitopes we pick, and are all epitopes of equal importance? And how do we measure them? How do we measure the differences? Franz Klaas and team from Leiden have actually been looking at this question and looking at different ways of matching. But I'll leave those aside for a moment. And Ruth Sepipakatsa, who's one of our co-leads, has actually begun to look at this in much more detail, the question of, are all epitopes of equal importance? And the answer, I think, she will show you and I will reinforce is no, we need to match for certain ones. So now the question is, how do we actually do this? So let's say we have a deceased donor come in. We have to think in practical terms. We have a very short period of time to actually achieve sequence information on the donor. We may already have sequenced the recipient, no problem. But our current methods of sequencing, so-called short range or short lead sequencing, can't be achieved within that period of 6 hours. So we began to work with new sequencing technologies, nanopore sequencing technologies. And when we first took this presentation to the Genome Canada interview. We have about 15 or 16 people ranged around us. Ruth will remember it very well. And one of their key questions is, why would you pick a technique which has such poor function? Because at that time, it was a very new technological experience and its performance was poor. But we actually said, we think this is going to change over time. And it's changed dramatically. James is just completing some of the validation now with Karen, and it actually shows we have virtually 100% accuracy in the sequencing information we obtain within a period of about 4 hours. This will mean now we can get sequencing information for all of our donors as they come through. So this has been validated in Vancouver, validated at McGill, and is now being translated across all of the 13 laboratories in the country. So technically, we're now entering a phase where we can plan for a Canada-wide epitope matching program. It will be a world-first initiative. We'll conduct it as a formal trial, starting phase 1, phase 2, and then moving through to full Canadian study. We'll describe over the next couple of days some of the new methodologic approaches to clinical trials that we'll consider for this and probably employ for it. I won't go into them just at the moment, but it will mean that we can actually use smaller numbers, get answers much more quickly, adjust as we go. So adaptive trial design in this application. So now let's assume that we could actually reduce the incidence of rejection. We need to begin to change our therapy because our therapy is built in a sort of one-size-fits-all for everybody because we don't have good markers about who needs what in terms of immune suppression. But now we will. The situation will change. It's like going into a store and there's only one size of suit. You, in essence, have to take it. That's not a very good outcome. Now we want to have tailor-made clothes for everybody. So we're beginning to use 3 approaches: systems pharmacology, understanding the pharmacogenomics, pharmacokinetics, pharmacodynamics, integrating them, developing new, rapid, short, small clinical trials, which are adapted from oncology to allow us to get the answer quickly, and then ultimately to use cellular therapeutics to enhance our approach to induce operational tolerance. So one of the questions which is very important is back to the issue of what do we select in terms of epitope matching? Are they all the same? Are they different? This is a little more work done by Jenny Tran here, looking at the question, really picking up the old question that came from Phil Halloran's team and asking, is antibody-mediated rejection still critical? Or has it really begun to diminish? And if so, who develops antibodies? What are they against? And what are the epitope targets? So looking here at just over 1,100 sequential patients over time, following all of those who were tested, asking what were the targets when they're tested. So let's look at some of the outcomes. The top line, the blue line, shows those patients who were never tested for antibodies. So these are the vast majority, 85% of the patients who really did extremely well, never had need for biopsy or need to be tested. The 2 lower lines are those who were tested. Some of them had antibodies, some of them didn't have antibodies. And the vast majority of these were also biopsied. And it shows that there wasn't a lot of difference really of whether you had or you didn't have antibodies. The question was, did the physician think you were doing poorly and wanted to biopsy and investigate you further? So when we look at the patients who developed antibodies, surprisingly, only a very small number actually developed them. Out of 1,000 patients, there were 60 who developed antibodies, 5%. You remember in that early picture from the Halloran group, where at the beginning in 2013, the number rose to about 60%. Here we're saying now it's about 5%. And the question is, what are those antibodies against? What do they target? So these circus diagrams show exactly what they target. The top half of the diagram shows the patients, and the bottom half of the diagram shows all the alleles for which they differ. The donor and recipient differs. It's not important to see the actual ones. It's only the colors which are important. So these are the antibodies that occur for HLA-A, B, and C. And you can see there are a few red chords, which are the ones with antibodies, but very few. These are the ones that occur for DR beta, class 2 DR beta. Yeah, few more. But when you look at DQ, the vast majority of the antibodies are against DQ and almost none against DP. And when you look at DQ, it's not all of the DQ antibodies. There are 51 epitopes, not all of the epitopes. There are 51 epitopes at present at DQ, not all of them. It's only a very small subset of them. And the question is, what is this subset? So we have two chains in the DQ, an alpha and a beta chain. And most of these, not all, but most of them reside on the beta chain. We would think they all occur within this region which holds the peptide, which is the highly conformationally changed period section. But that's not the case. Many of them do, but some occur down here on the framework region of the molecule as well. So we're getting closer and closer to being able to say not only is epitope matching feasible, but also it's biologically important, and then it gives us a chance to identify the key molecular markers. So with this in hand, we can ask, what would happen if we actually matched all of these people well? And this is work that James has done looking back over the last 1,000 cases. And we see if we look at the green line, these are perfectly epitope matched individuals, zero risk of any rejection. Even if they're closely matched, up to 3 molecular mismatches, they have almost no rejection. So we're getting to the point where we're actually saying that the incidence of AMR is now below 1%. It's actually 2 cases in the last 1,000 patients, and classical non-antibody mediated rejection is almost 0. Let me move from that. This is really the business end of the next step. And it says, now given that rejection is disappearing, how do we change our immunosuppression? And it's a very complex question. We first have epitope matching, then we'll have immune monitoring, then we'll have personalized therapy, and we need to bring in a lot of different characteristics. Ruth has an excellent article which includes this, which we'll refer you all to later. And then the final step, which we hope will be in the next coming few grants, takes us to the question of operational tolerance. Now we have a perfectly quiet sea, like a balmy evening off Barbados, and we're just going for a swim. Can we actually capitalize on that to minimize immune suppression dramatically, and then to use cellular therapeutics to induce operational tolerance? And our Canadian government has been very kind over the last year or so, with great largesse, has invested over $500 million in bioengineering. And it has brought together 5 or 6 of the main universities across the country in biomanufacturing hubs, and BC is leading the one in cellular therapeutics. So that's the group that we will be working with in this field. Now, when we put the grant in, patients go home all over the place, and BC is a wonderful test province, because the universities are down here in the bottom left-hand corner, but the size of BC is actually larger than the combined areas of Germany and France. So we need now to care for 5 million people who live distributed across from northern Germany to the French Riviera. How do we do that? Really complex. So we need sophisticated and instantaneous immunological monitoring, which will mean we have to change how we follow and deliver care. There will be a whole series of techniques. We'll use deep phenotyping, transcriptomics, proteomics, series of others. One of the important ones is looking at T-cell receptor gene utilization, because this is the first thing that will tell us about clonal expansion. These are all just in process of being evaluated and followed up. I just bring us to one important area. If rejection is disappearing, why are people still losing their grafts? And it's because of other factors. It's because of infection, recurrent disease, and a variety of others. And we've spent a lot of time looking at questions of viral infection, including CMV. We've taken data from COVID and we've asked, can viral kinetic monitoring that was used for COVID be translated to the other viruses? And the answer is yes, of course. Viruses are viruses. We can actually look at the area under the curve for viral titers. And the bigger the area and the longer it is, the greater the risk to patient survival and to graft survival. And in fact, we have composite risk phenotypes. Now we can put together a variety of things: age, risk of disease, area under the curve. And if you fall into the highest risk group, you can see that you have a major problem. So these are other problems that we need to deal with quite apart from immune suppression. So let me bring it to a close. Our final goal is evidence-based health policy and technology transfer as a country. Louisa and team will bring you some of the tremendous work that they have been doing in this area with distributed democracy, with economic modeling. We hope to put these together for a national program. We want to bring together the public, patients and providers in a discussion and a full evaluation to demonstrate the benefit that we do. And then we will take this back to Genome BC and Genome Canada and ask them, Julia, for another $20 million. Thank you. Michael.
50% of DSAs do not cause a rejection. Could you characterize those with your exciting technology to find out whether they are harmless?
So this is a really interesting question, Michael. I must say we're really just broaching it. I don't know which ones are going to be, but the ones that look to be most common and most deleterious are the ones, a certain cluster of those which bind to DQ beta, right. And others seem to be, they're often associated with those, but individually they may not be as deleterious.
So there is a potential in the future, yeah, to see what is dangerous and what not.
Yes, I believe so. But the real goal is to prevent them occurring at all. Yeah, and we have increasingly strong evidence now that one of the reasons that they develop is because we remove immunosuppression. In other words, the patient doesn't have adequate immunosuppression, either because the patient has toxicity or other reasons and stops taking the medication, or two, for example, in the case of CMV, the physician sees patients become leukopenic, we better back off your immunosuppression, and we never reinstate it.
Excellent.
Right. Please, Ahmed.
Excellent talk. So my question here is about the molecular mismatches and allocation. I think it's going to be a challenge with the visible minority population in Canada and how this will not impact the allocation for visible minority, because they might have higher mismatches.
So a fascinating question, which we looked at. So Oliver, Karen, and other members of the team have taken this question. James may actually be able to speak to this when he gives his presentation. Surprisingly, when we look at the frequency of alleles, we have some alleles which are common and then a rapid decline, and most alleles are relatively uncommon, less than 1%. But when we look at the distribution of epitopes, it's a much more common, uniform, linear presentation. So epitopes are much more commonly distributed through our population. We look then according to ethnicity. Very little differences. James has looked at the potential of epitope matching versus ethnicity. Very little difference. So not to say there's zero, but actually dramatically less than we thought there may be. We're now you remember that curve with the little red dots at the 40 dots at the right hand. We're now looking at that to see if that's an ethnically balanced group for the BC population. We don't know, but we think we can answer your question very soon.
Thank you.
Thank you. Shall I pass back to Karen?